Hello, Dr. Brazier here. Welcome to this video on sexual dysfunctions, gender dysphoria, and paraphilic disorders. So let's start with sexual dysfunctions. So we know that the normal sexual cycle, at least as it has been historically described, begins with sort of a desire and an interest, progresses to a phase of growing excitement, which then progresses to orgasm, and then that final stage is resolution. Now, this is historically what has been described, but it has been shown to be accurate for the male sexual cycle. As a lot of things that were researched in prior decades, the male experience was considered to be the normative experience, but actually different models that are more complicated have been used to describe sort of what the normal sexual cycle can look like for females, which looks more like maybe an upward spiral. Okay, so just keep in mind that if you see models for what is normal, if they've been normed on males, then you can wonder if there may be differences according to different cultural points of intersectionality. Okay, so sexual disorders are sort of categorized under first desire/arousal/interest disorders like erectile disorder, female sexual interest/arousal disorder, and male hypoactive sexual desire disorder. Then there are the orgasmic disorders, so female orgasmic disorder, early ejaculation, and delayed ejaculation, sexual pain disorders, and then genitopelvic pain and penetration disorder. So a little bit about the sexual disorders. First, you need to make sure that there's adequate sexual stimulation before you make a diagnosis. This is not something, obviously, that you're going to be observing. So you need, if you're going to work with a sex therapy as a part of your practice, which if you're interested in couples, working with couples, you either need to have increasing acumen in working with sexual dysfunction issues, or you need a great referral base that you can refer out to for working with specifically sexual issues. So a lot of people say that the couple's sex life is a pretty, typically, not always, right, but typically a pretty good indicator of the health of their relationship as a whole. So anytime that sex therapy is a part of the equation, I think that couples therapy in general should be part of the equation as well. And any time that the distress within the couple relationship has led to sexual struggles, then you also need to be able to have a way to address those. So you need to be able to ask great questions that can help reduce stigma and shame, and help get a really clear and accurate picture of what's going on before you offer a diagnosis. Because if adequate stimulation is not occurring, then you might misdiagnose something when it's just, in fact, that the stimulation is not there. So you need to differentiate between something that has been lifelong versus something that has been acquired, perhaps through trauma, acquired, or dysfunction that's been acquired through relationship struggles. And whether it's generalized versus situational. In other words, is it all types of stimulation or only certain types? Is it all types of situations or only certain? Is it all partners or only certain partners? So getting a really clear picture through really intentional assessment can be very helpful in offering an accurate diagnosis of the problem and in tailoring treatment accordingly. So you need to consider partner factors like the health of the partner and any sexual problems that the partner might have as well. Relationship factors, like I said, so poor communication, differing expectations, if there's been wounding in the relationship. Individual vulnerability factors like poor body image or a history of sexual abuse. Those are huge. You must assess for those. Now keep in mind that a trauma-informed approach doesn't assess for details of the sexual trauma, but it does assess for if this occurred in general so that you can have a high level of diagnostic acumen when you're making diagnoses. Psychiatric comorbidity. So is there also co-occurring depression or anxiety? Because if there are, you're going to go with those diagnoses first, because it may be that the sexual dysfunction is a result of some of these factors. Also stressors, like has there recently been a loss, like a loss of a job or a loss of a loved one, or a change, a big change, like a move or something like that, that sometimes brings losses with it. You need to consider cultural or religious factors. So have there been cultural or religious factors that have impacted the person's view of sexuality and made it seem to be something that is wrong, bad, dirty, what have you. And then medical factors. So there are known side effects to some medications that will impact the sexual arousal, the sexual desire, all those things. So you need to be really assessing well in order to make sure you're understanding the actual cause of the problem so that you can treat it properly. Even if you're not going to offer a formal diagnosis, you've still got to get a really clear picture of the cause so that you can treat appropriately. Otherwise, you'd be treating something that's not even actually the cause of the problem. So let's take them individually. Erectile disorder, you have to have one of three symptoms on 75 to 100% of occasions of sexual activity. So either marked difficulty in obtaining an erection, marked difficulty in maintaining the erection until completion, or marked decrease in rigidity of the erection. Has to last for at least 6 months, has to cause significant distress, and you can specify the level of distress as mild, moderate, or severe. Has to be, you have to make sure you specify whether it's lifelong versus acquired, generalized versus situational. So clearly with this one, as we know, there is an age-related increase, particularly after age 50, in this specific disorder. 13 to 21% of men 40 to 80 years of age complain of occasional problems with erection. It's very common. So even just having an awareness of that statistic and being able to normalize this struggle can be helpful. 40% to 50% of men older than 60 to 70 may have significant problems with erections. It is also, though, common with PTSD or depression. If those two disorders, either of those two disorders is coexisting, then erectile disorder is going to be potentially an effect of it. And so you need to explain it that way, that because of your depression or because of your PTSD or other factors, keep in mind that anxiety can lead to depression. And so whatever, but explaining that that can have an impact on their erection is really helpful for normalizing this struggle and also for removing fear that it will always be this way. In other words, if you can say, as the PTSD is healed, as your depression resolves, this may change as well. And if it doesn't, we can address that then, but this is not necessarily for everything. There's lots of hope here, can be very helpful. So one test for erectile disorder is called the nocturnal penile tumescence testing, and it measures the erectile turgidity during sleep. So it's called the stamp test because it used to use a roll of stamps. The male would place the stamps licking so that it would and wrap around the penis and then attach, so that if in the night the penis did get erect to some degree, the stamps at the perforations would break, and then you would know that it's maybe more of a psychological issue rather than a physical functioning issue, because in fact the male is capable of getting an erection. It just may be that there are psychological factors at play that are causing it to that are causing that person to have a struggle. So ultrasound can also be helpful. There are some invasive procedures to assess the vascularity, but those would be more of a last resort. And of course, all of this would be conducted under a doctor's administration and not counseling. But it's helpful to know that you can refer clients to their doctors for different things. There can also be nerve conduction studies, testosterone level tests, thyroid level tests, glucose level tests, lipid level tests, because a lot of different factors could be impacting this. And So referring them to their primary care doctor for a full screening, and then the primary care doctor may want to even refer them out to some other specialist. But making sure that that occurs is a really important part of treating this disorder from a counseling perspective, a proper referral. So female sexual interest / arousal disorder, there needs to be a lack of at least 3 of the following: absent or reduced interest in sexual activity, absence or reduced sexual or erotic thoughts or fantasies, no or reduced initiation of sexual activity, unreceptive to partner's attempts to initiate, absent or reduced sexual excitement or pleasure in 75 to 100% of the encounters, absent or reduced sexual interest or arousal in response to any internal or external sexual or erotic cues, absent or reduced genital or non-genital sensation during sexual activity. So it needs to have lasted for at least 6 months and to cause significant distress, again, mild, moderate, or severe. Need to, again, specify whether it's lifelong or acquired, whether it's generalized or situational. And it's not just a desired discrepancy between the two partners. In other words, you don't measure disorder or dysfunction compared to the partner's level. You must measure it against sort of the measuring stick of the individual person rather than as a comparison to their partner. Because it's very common that there would be desire discrepancies in couples. That's a very common phenomenon. And helping couples learn to sort of navigate and negotiate those is part of competent couples therapy. But this is different. We don't measure whether one person is experiencing dysfunction or disorder compared to their partner. Short-term changes are common. In other words, there's lots of fluctuation. You need to keep that in mind. Check for relational difficulties, negative cognitions about their own sexuality or sexuality in general, mental disorders, and then other sort of physical factors, medical factors like diabetes, thyroid issues, or genetics. Then there's male hypoactive sexual desire disorder. So that's persistently deficient or absent sexual or erotic thoughts or fantasies and desire for sexual activity. And you've got to judge that either by what they're telling you or, again, by their own gauging of themselves comparatively. It's got to persist for at least 6 months, cause significant distress. You've got to specify, like we said before. It's sometimes associated with erectile or ejaculatory concerns, but not always. 6% of men age 18 to 24 are diagnosed with this. 41% of men age 66 to 74, but persistent, which is greater than 6 months, is 1.8% for ages 16 to 44. There's a normative age-related decline in sexual desire, and potency of sexual cues may decrease with age as well. In other words, what constituted a sexual cue for a man in his 20s may no longer constitute a sexual cue for a man may decrease as the decades grow. Mood, anxiety symptoms are strong predictors. Alcohol use can definitely impact this. And testosterone levels and age and other factors. So there's also delayed ejaculation disorder. So you got to have either symptom 75 to 100% of the time for partnered sexual activity. So notice this is partnered activity, right? Either a marked delay in ejaculation or marked infrequency or absence of ejaculation for at least 6 months. Again, distress level and whether it's lifelong or acquired, generalized, or situational. It's the least common complaint for males, sexual complaint. The incidence increases around age 50, and men in their 80s report twice as much difficulty with ejaculating as those in their 50s because of loss of sensory nerves, and the steroids that impact sex secretion also decrease with age. If it's situational, then you can suggest that there might be a psychological component, gender of the partner, paraphilic patterns, things like that. But if it's not situational, if it's more generalized, then that won't be an issue probably. And if it's medical, there could be nerve damage that occurred during surgery, neurodegenerative issues, diabetic issues, alcoholic neuropathy. A lot of different things can cause delayed ejaculation. as can medication. So antidepressants, antipsychotics, antihypertensives, and opioids can all impact ejaculation. And then on the other end of the spectrum, there's premature or early ejaculation. So that's persistent or recurrent pattern of ejaculation during partnered sexual activity within approximately 1 minute following penetration and before the individual wishes it. It's got to last at least 6 months and be present for at least 75% of the time and cause significant distress. And then you're going to specify. So with new definition of 1 minute as opposed to previous in the DSM-4 and earlier, only 1% to 3% of men would be diagnosed with this. One minute is a very short time span, and so it shortened the time span, which significantly decreased the number of men who would actually meet criteria for this. It's more common in anxiety disorders, especially social anxiety disorder, for this premature ejaculation issue to manifest. And thyroid disease, prostatitis, and drug withdrawal can all impact it. So then there's female orgasmic disorder. So either of the following must occur in at least 75% of sexual encounters: marked delay in frequency or absence of orgasm, or marked reduced intensity of orgasmic sensation. You've got to have at least one of those at least 75% of the time. It's got to persist at least 6 months. It's got to cause distress. You got to specify. And it can't be better explained by another medical disorder or by effects of medication or a medical condition or interpersonal or significant contextual factors. So that's a lot to rule out. And so this disorder would take a long time and a lot of really intentional assessment in order to make a proper diagnosis here, because it's a lot to rule out. Studies vary in estimations of prevalence, 10% to 42%. That's a wide range. 10% of women don't experience orgasms in their lifetime ever. So that's a pretty significant amount of women. And that too can be helped to normalize, reduce stigma, reduce shame. Risk factors for female orgasmic disorder include anxiety, concerns about pregnancy could definitely impact this, relationship problems, health problems, mental health problems, sociocultural factors, and religious norms can also greatly impact a woman's ability to reach orgasm. And then there could be pelvic nerve damage, spinal cord injury, SSRIs can inhibit orgasm, vaginal dryness from atrophy, which can occur naturally with aging as well. And then there's genitopelvic pain or penetration disorder. And you've got to have at least one of the following difficulties. Vaginal penetration during intercourse causes pain or is not attainable. Marked pain during penetration attempts. Marked fear or anxiety about pain. So this is in some ways similar to panic disorder, where if a person experiences a panic attack, there now is additional anxiety, not only around whatever the person was already experiencing anxiety around, but anxiety about having another panic attack. So this is similar here, where the person has experienced pain during penetration in the past, and now there's this added layer of fear or anxiety about experiencing pain in future sexual encounters. Marked tensing or tightening of pelvic floor muscles during attempts, and this is of course, this is unconscious. This is something that the person is not causing. This is something that feels out of the person's control. It's got to persist for at least 6 months, distress, and you got to specify. Okay, so treating sexual dysfunctions. Huge in all of these is anxiety reduction. So one method of anxiety reduction is systematic desensitization, where you would work with the client or couple to make a list of anxiety-provoking situations from least anxiety, and then you would order them from least anxiety-provoking to most anxiety-provoking, and then you would teach. First you would teach. You would teach relaxation strategies like breathing strategies, grounding strategies, what have you. And then you would make a list of anxiety-provoking situations, order them from least to greatest, begin with the least anxiety-provoking, and they would choose to engage in that activity. It requires courage, but it's possible to do. Choose to engage in that activity, and if the person becomes super triggered, then they have those strategies to self-soothe and calm, and then that would that they would continue with that very first level, least anxiety provoking, until it no longer elicits an anxiety response. And then and only then would they move on to the next level. Now, this is challenging in ways that, like, reducing phobias and things like that is not, because obviously the couple is not having sex in your presence. They're not engaging in these sexual activities in your presence. And so you've got to find ways to coach them and help them without actually being there to observe or facilitate. And so it takes a lot of skill and understanding of how to help with these issues in an appropriate way. So one strategy that can be helpful with anxiety reduction is something like equine therapy. So in equine therapy, the horse acts as a sort of in real time indicator of what's happening in the people's bodies. The horse will react based on very, very subtle cues that the person may not be picking up on in themselves. Their partner may not pick up on, you as the therapist may not pick up on, but the horse will pick up on it. Any increase in breathing, heart rate, tenseness, bodily tenseness, the horse is super sensitive to those cues about anxiety. And so an embodied method of learning to self-regulate can occur in something like equine therapy beautifully. It's perfect for stuff like this. And so it's interesting because, of course, in your textbook, a lot of the preferred recommended methods for treatment of most of these issues is CBT. And in these sexual dysfunction issues as well, CBT is recommended heavier on the behavioral side. So like systematic desensitization comes out of the behavioral camp, not so much cognitive. And here's why. We can know all kinds of information, but that doesn't necessarily impact our body's reactions and responses. And so you need a way to treat these disorders that is a more embodied method. So something like Gestalt, something like equine therapy, may be very helpful. Bilateral drawing. There's all kinds of different ways to access the body and treat the body. So procedures to change attitudes and thoughts. Sensate focus is a wonderful stepwise process that relieves the stress of fixing the end result, whether that's orgasm or penetration or whatever, and it slows everything down to a beautifully slow motion process, and it can be very effective in treating a lot of these sexual dysfunction issues. And of course, there's a CBT component to it, which is challenging the beliefs. So I should orgasm every time. I should be able to orgasm, through without clitoral stimulation. There's something wrong with me because I can't ejaculate quickly enough, or I ejaculate too quickly, or so really challenging these beliefs, this all or nothing thinking, this self-shaming and self-blaming can be really helpful CBT wise. And then I encourage too, and I didn't list it here, but I encourage some either mindfulness practice, which I think is fantastic and could be very helpful. Mindfulness practice could be hugely helpful in treating sexual dysfunction. Because a person can recognize that there are thoughts, such as spectatoring impulses, where the impulse is to observe my performance rather than sort of staying in my body with the feelings. Or I can observe emotions that come in and flow out, but I don't have to over-identify with the thoughts or over-identify with the impulses or over-identify with the emotions. I can recognize that they come in and flow out. So mindfulness practice could be hugely helpful with sexual dysfunction, as can be self-compassion practice. Self-compassion practice, treating ourselves kindly the way that we would treat someone else who is suffering, with empathy and concern and care. The common humanity piece, so that's that normalization piece, recognizing that this is very common for people to struggle and you're not alone in this way, that lots of people suffer at least at some point in their lives from some sort of sexual dysfunction issue. And then that mindfulness piece is part of self-compassion practice as well. So practices are not a one and done thing. Practices are something that we get better the more that we do. So helping your client find and engage in intentional practice of mindfulness and or self-compassion could be hugely helpful to treat sexual dysfunction. And then there's skills and communication training. This says show videos. That's been a strategy that's been used. I would strongly question any videos that could be considered by anybody, either partner or even you as a therapist, to be hypersexualized in nature, because the intention is not for the videos to become the source of interest or arousal or desire. This is very dangerous ground, I believe. Pornography addiction is so prevalent that I would be very thoughtful about using this as an intervention. But partners can discuss their likes and dislikes without watching videos, right? Partners can be, and this kind of conversation can be facilitated by you as the therapist, as long as you've done your own work enough to be comfortable facilitating these and understand how to do so in an ethical and respectful manner. And then, of course, couples therapy, like I mentioned before. So sex problems are viewed as one aspect of a complex network of relationship factors, and they interact. So the health of a couple's sex life is going to impact the health of the relationship as a whole, and the health of the relationship as a whole is going to impact the health of their sex life. And then focus on non-sexual issues of the relationship as well. So even if a couple reports only to sex therapy, only for sex therapy, it would be negligent on the part of the sex therapist to neglect those other couple issues. And then there are medications that are used to treat some of these, Viagra, Cialis, and Levitra. And those can be very helpful. And I think sometimes sort of a multimodal approach is best, where you're providing the referral to the doctor for the medication piece, but you are also providing therapy. And help couples recognize that if a medication helps with this, that's exciting. That doesn't mean that there aren't other issues that could be improved, other ways that therapy could help. Because I would imagine that if a couple finds a medication that fixes the problem, they might be tempted to sort of prematurely terminate therapy, just quit, stop going, because, hey, we found the pill that fixes these issues. And you as the counselor know that there is more health that could be achieved, but they may not know not to settle for less. Let's chat about gender dysphoria now. So although not all individuals will experience distress as a result of such incongruence between the gender that they have, that they were assigned at birth, and the gender that they feel they are on the inside, many are distressed if the desired physical interventions by means of hormones and or surgery are not available to them. The current term is more descriptive than the previous DSM term, DSM-4 term, gender identity disorder, and focuses on dysphoria as the clinical problem, not identity per se. So whereas in earlier iterations of the DSM, having a feeling as if one is a gender that is different from the gender that one was assigned at birth, or that the world tends to see, was considered disorder, where now it is considered not disordered at all. The disorder is supposed to come in only with dysphoria at the difference. So that's obviously a political shift, and to assert that the DSM is not a political book is to be naive, right? So currently there's, I hear a few terms to be up on as you're talking about the issue of gender dysphoria. So gender is the public or legal lived role of the person. It is not the same as sex. Sex is genitalia based. Gender is public or lived role, so it's socially constructed. Gender assignment is the initial assignment as male or female. Gender atypical or gender nonconforming are the terms that are used when the person does not match. So the assignment doesn't match what they feel on the inside. And gender identity is, again, socially constructed. It is a social identity. Gender dysphoria is unhappiness at the gender that one is showing the world, at one's social gender identity. Transgender is a person who identifies with a different gender, and transsexual, the difference between these two is transsexual is the one who has undergone social transition to another gender, which can also involve physical transition. So either through hormones or through surgery or something they've undergone some kind of medical procedure to alter the transition that they are showing the world. But people can be transsexual without any hormones or surgery if they are changing how they are presenting themselves to the world. Gender dysphoria in children. So there's a marked incongruence between their experienced and expressed gender and the assigned gender, at least 6 months duration, with 6 or more of the following: strong desire to be the other gender, strong preference for cross-dressing or simulating female attire for girls, strong preference for masculine clothing and avoiding female clothing, strong preference for cross-gender roles in play for little kids, strong preference for toys or games of the other gender. In boys, rejection of masculine toys and vice versa. In girls, rejection of feminine toys. Strong dislike of one's anatomy. Strong desire for sex characteristics of the experienced gender, and has to cause clinical significant distress or impairment. Let's talk about gender dysphoria as it progresses for adolescents and adults. So there has to be a marked incongruence between experienced expressed gender and assigned gender, at least 6 months, at least 2 of the following: marked incongruence between expressed gender and primary or secondary sex characteristics, strong desire to be rid of sex characteristics because of marked incongruence, strong desire for sex characteristics to be of the other gender, strong desire to be the other gender or some alternative gender different from one's assigned gender, strong desire to be treated as the other gender, strong conviction that one has typical feelings and runs with the other gender, and clinically significant distress or impairment. Again, that always has to be present. So let's talk a little bit about treating it. First of all, one highly recommended treatment is diminishing stigma. So persons experiencing gender dysphoria need a diagnostic term that protects their access to care and won't be used against them in social, occupational, or legal areas. Hence, the replacement of the word disorder with the word dysphoria. It removes the connotation that the person has a disorder or is disordered, and it avoids jeopardizing their access to care. I'm not sure why that didn't load. Okay, counseling. So I want to talk a little bit about some issues here. I believe that counseling people with gender dysphoria has become highly politicized. And I think that a lot of counselors who are pro transformation, gender transformation, are the loudest voices in the conversation, that they are the ones that proclaim themselves to be experts in treating people who identify as LGBTQ+, which includes the transgender piece. And because they are the loudest voice and because they are proclaiming themselves to be the experts in this topic, then they are the ones treating the clients. My struggle with that is that I think a lot of times they push ideas and referrals prematurely. And here's what I mean by that. As counselors, we come with a developmentally informed perspective. That means that we recognize that at different stages of development, people will have different struggles, and they will have different focuses, different values that come to the top of importance for them. So when we talk about adolescence, what we know from a ton of literature on typical development is a few things. First of all, we know that there's a lot of hormonal changes that adolescents undergo. So adolescence is the most hormonal changes a person will undergo, save for those very early years of life. And then the only other one that is typical, other than like the aging and the decrease of hormones, is when women are pregnant, their bodies undergo some hormonal changes. But adolescence is a time of huge hormonal change and upheaval and surge. And because of that, their sexuality tends to come to the forefront in adolescence, whereas it was not in the forefront as much in childhood. The other thing that tends to come to the forefront in adolescence is the seeking of an identity that is different from one's parents and the seeking of a tribe with whom to identify. And so when you put all these issues together, you can recognize that adolescence is sort of a hotbed for gender dysphoria and other issues like that, because the sex hormones are raging at the same time as these young people are looking for their own identity and their own tribe. And I believe that what that can sometimes cause is a conflation of things that that are not supposed to be conflated. In other words, there's a difference between one's identity and one's sexual attraction and one's sexual behavior. And I think that they have all been merged in a lot of the literature and in a lot of the treatment, and they should not be. For example, my identity is not primarily about my sexual orientation. It is a piece of my identity, it's a piece of my cultural intersectionality that I am heterosexual, but that is not at all how I would self-identify as the forefront of my identity. So for me, what's most important to me is that I self-identify as a Christian. I identify as a woman. I identify with the dominant culture of white and recognize that there has been privilege that has been allotted to me that I did not earn, right? Privilege is not earned simply because of my skin. I identify as middle-aged, right? And I identify as a role of wife and the role of mother more than I identify with my sexual attraction. And so that's for me way down on the list. But I believe that with this surge of interest in coming alongside and helping people whose sexuality, whether it's an orientation or a gender issue or something like that, that it differs from the norm, in an effort to support them and to care well for them. The pendulum has swung so far, in my opinion, that it becomes their primary identity. And I don't think that our primary identity was ever necessarily supposed to be tied up in our sexual attraction. We wouldn't want that for heterosexual teenagers any more than we want that for homosexual teenagers, any more than we want that for people who identify as cisgendered, any more than we want that for people who identify as more gender dysphoric or transgendered. And so why that has become the primary mode of identity, I think, is something to consider and ponder. In addition, attraction and behavior are not the same thing. A person can experience attraction to different kinds of people, especially when those hormones are raging in their adolescent years, and doesn't necessarily have to impact their behavior. So as Christians, for example, we believe that sex outside of marriage is sinful behavior, regardless of the person with whom the person is having sex, right? We believe that it is sinful to have sex outside of marriage, outside of the covenant of marriage. And so because of that, the behavior piece for a lot of this kind of goes off the table. And so I just want us to really be thinking about the differences between identity and attraction, which may not be considered sinful, and behavior, which at its most extreme is actual sexual activity, but even backing that up may be lusting, right? Jesus said that lusting is also sinful. It is if that person has committed that sexual behavior, but lusting in and of itself is a sexualized behavior, in that it is choosing to ponder and seek out and think about these things rather than a spontaneous feeling of attraction that is then, moves through. So just being really intentional about how we think about these things. And then I think about the idea, there's a lot of talk right now about gender affirming, that we need to affirm the person's gender. And I don't necessarily feel the need to be affirmed in my femininity. And so I think that this is very interesting. And I, as a counselor, would be much more interested in identity and affirming, in that I help my client, regardless of who they are, recognize what pieces of their identity that matter the most to them, aligning with their values. And that I am affirming, that I'm helping them affirm those pieces and operate out of those pieces primarily. And then I think there is some worth in the idea of helping the person increase their self-efficacy, so they feel like, I can do hard things, I can make it in the world, I believe in my own ability to face obstacles and overcome them. Increase in self-compassion, like I said earlier with the sexual dysfunction, how I treat myself when I'm struggling. And increase community feeling. I have heard it said, and I really find this very interesting, that all adolescents are narcissists. And that's, I think, a very interesting tack, because adolescents tend to be very, very, very self-focused. Now, it's typically in a negative fashion. Negative self-evaluation, worry that all others are looking at them, worry that all others are thinking about them, worry that all others are judging them, worry that they don't fit and others are looking down upon them. So it's not necessarily a positive self-focus, like I'm the greatest, I'm the best. It's typically more of a negative self-evaluation, but it is a constant self-evaluation and self-focus. And so helping adolescents shift their focus toward helping others in meaningful ways, I think could actually be very beneficial in this counseling process. There is the possibility for physical alteration, so cross-sex hormone therapy, which is often called a second puberty. So you're messing with genetics, you're looking at the age at which the hormone therapy begins and the overall state of health of the person. And then the most extreme end of it is gender reassignment surgery, where the person undergoes specific surgical procedures to change their appearance. So male-female hormones that can be given to a person with gender dysphoria can impact a lot of things. It's going to make the skin drier, thinner. It's going to make pore appearance smaller, and there's going to be less oil production. The person is going to be more prone to bruising and cuts. The odors of the person's sweat and urine are going to change. Their perception of touch is going to be altered. There's going to be sensitivity to pain and temperature that's different than it was before. Small buds are going to develop beneath the nipples that are going to be sensitive and painful. There's going to be a fat redistribution that occurs. So hips and thighs are going to be areas that are going to be more impacted. And there's going to be a loss of muscle definition and an increased facial fat that's going to cause the facial features to soften. The person may gain or lose weight as a result of the hormone therapy, and hair may decrease in thickness and grow more slowly. Now, some of these changes will revert if this hormonal treatment is stopped. In other words, in order to maintain the full effects, the person is going to be on these hormone therapies for the rest of their lives. However, some of them may be less prone to be altered. They may be more permanent. And I think that this is not being thought through enough in this trans affirming push that some counselors who align with a certain political view of this issue. I'm not talking about like whether, what their political aspirate, like Democrat or Republican. I'm talking more about political reviews based on this issue in particular, that they may be pushing a certain path of treatment that in some cases can have some effects that are irreversible at a time of flux. So when a person is in adolescence, they are not fully formed in their brains. We know that their prefrontal cortexes are not fully developed, and their bodies are not fully developed either. Their decision-making capacities are less. There are actual laws in place to show that we as a culture recognize this. So you have to be 18 in order to do certain things. You have to be 21 in order to do other things. But in order to engage in these treatments, some of which may be permanent, if a parent consents, you don't have to have reached adulthood in order to make these kinds of decisions that have permanent impact. And I think that this developmental perspective is being missed sometimes in efforts to support people who experience gender dysphoria well. And I question the ethics of it. So, it is also true that these hormonal treatments can take 2 years or longer to reach full effect. And I think there is a lot, dysphoria, right, means that the person is unhappy about the current way that they appear to the world versus the way that they feel on the inside. And so the idea of waiting for a long period of time in order to see the full effect of hormonal treatment may be difficult for some people. They may feel that they would like those effects a lot faster, and they may tend to take higher doses of the hormones than is recommended by medical professionals. And taking these more faster does actually not do any good to hasten the effects, but it does endanger the health of the person. Okay, and so in our field at large, advocacy is something that is being very pushed right now. And so you definitely want to think through your choices of how you advocate for this population. I think advocating for this population is very important. For example, people who are diagnosed with gender dysphoria tend to have a very high rate of suicide attempts and suicide completions as compared to the general public. So this dysphoria is very real, and it may coincide. Remember, I told you highly comorbid with some other disorders, but it may indicate that I think it indicates that this population does need to be advocated for. But how we advocate for this population is very important. We need to think through things and advocate ethically. So you can advocate for social and legal transition to the desired gender if you believe, after pondering this and wrestling with this, that that's appropriate. But you could instead advocate for anti-violence and anti-discrimination initiatives. In other words, it's not okay that people who are either experiencing gender dysphoria or who are taking action to become more like their desired gender, the gender they feel on the inside, that they would be the victims of violence or discrimination. That's not okay. And so focusing advocacy efforts toward that goal may line up more with how you end up believing. And then, so there's also special cases like divorce custody disputes. And I've actually experienced something to this effect where there's a divorce situation. One parent wants the child, the adolescent, to undergo hormonal therapy treatments for gender dysphoria, and the other parent disagrees with that decision. And so there is just almost a tug of war with the child. And so learning how to advocate on the child's behalf, it can be very helpful. Okay, and then let's talk briefly about paraphilic disorders. So characteristics of paraphilic disorders: most people with atypical sexual interests don't meet criteria for a mental disorder because it requires that people who have these interests that diverge from what would be considered normal sexual interests, it requires that they feel personal distress about their interest. Not only distress about the fact that society disapproves of it, but it's got to cause them distress. And that's pretty rare. Also, they have to have a sexual desire behavior that involves another person's that it has to involve another person's psychological distress or injury or death, or desire for sexual behaviors involving unwilling participants or persons unable to give legal consent. In other words, a person may not feel distress about being sexually attracted to children, like pedophilia, but if if acting on their sexual interest harms another person, like a child, who cannot give legal consent, then that may actually be a requirement that could help with diagnosing a paraphilic disorder. So the paraphilias are fetishistic, transvestic, pedophilic, exhibitionist, voyeuristic, sexual masochism, sexual sadism, frauduristic, and not otherwise specified. And there's a whole bunch of diversity in the ways that sexual interest and desire and practice can deviate from what is considered to be sexually normative. So etiology. This is overwhelmingly diagnosed and identified in men. So it may be that androgens play a part. Classical conditioning is also another potential source of paraphilia. So repetitively linking a sexual arousal that's normal. Sexual arousal is a normal experience of humans, but linking it with inappropriate stimuli can actually result in paraphilia. So then, of course, classical conditioning like Pavlov. Then there's also the option of operant conditioning as an etiology. So if a person comes to their sexual experience with sexual arousal, but also inadequate social skills, they may deviate and turn to some other substitute method to get those normal, healthy sexual arousal needs met. So it's a substitute, and then that is a reward when that sexual release occurs, is a reward, and so then it would reinforce the continuation of that pedophilic behavior. So childhood sexual abuse does play a role here. A person is 3 times more likely to be a sex offender if they are a survivor of childhood sexual abuse. But then 1/3 of people who are sexual offenders do not report sexual abuse. So it definitely seems to play a role, but it's not completely predictive in that way. Of course, also, lots of survivors of childhood sexual abuse do not go on to be abusers. For those who were abused, and they did abuse, it was often when the boys reached adolescence. So there may be some sort of a time range piece of this. And then if there was neglect, if there was family violence, if there was a lack of oversight and supervision, in other words, no one's watching the children for a variety of reasons. Maybe it's because of substance abuse. Maybe it's because the family members were, there's a lot of chaos in the family structure, divorce, or separation, depression or other mental illness, psychosis in the family system. Then no one is watching the children and what happens to them. Or abused by a woman. So this also may be a predictor that a person may become, that a survivor of sexual abuse may become a perpetrator if the abuser was female. There's also cognitive distortions at play here. So it has been noticed that there is an increased level of hostility, hostile attitude toward females, and also a real distortion of interpreting other people's desire. So with voyeuristic and pedophilic, it's this cognitive distortion of they wanted it, they liked it, they were into it kind of a situation. And then alcohol and negative affect often are immediate triggers. So when a person abuses a substance, and I would add other substances in with alcohol, they are more likely to perpetrate. And when they are feeling down or low, they are more likely to perpetrate. And so when we look at the cycle of addiction and we look at low self-worth, low mood, low affect, whether that's guilt and shame, or whether that is sadness, feeling of hopelessness, helplessness, depression, anxiety, that will then trigger another abusive episode. Okay, treating paraphilic disorders. So if the paraphilia results in illegal behavior, like pedophilia, like exposing oneself, in public, those kinds of things. If it's illegal, then it may lead to court-ordered treatment. And of course, if it's illegal, it's likely to go untreated because the person may not experience distress about it that would lead them to overcome the shame and the fear of judgment of others in order to seek mental health help. Biological and psychological treatment can help. So 1 in 3 people were less likely to repeat offenses if they received mental health help of some kind than those that received no treatment. So it can be helpful, psychological treatment. But interestingly, it may not be helpful in the ways that society would typically go about it. So it may not be helpful, as far as research is telling right now, to try to increase empathy toward victims. It may work, but often we would assume that it would work, and it may not work. But there are other things that have been shown to be helpful. So one thing is to increase the motivation for change by empathy coming from the counselor toward the client. Now, this can be very difficult to do because one barrier to empathy is aversion to harm of others. And so it takes a special kind of counselor who either, can recognize the value that this person has, for example, as a child of God, despite their behaviors and choices that have harmed others. So working through that from a theological perspective, and or working through any aversion that rises up in the counselor just because of like a feeling of disgust or a feeling of anger, a feeling of defensiveness for the victim, because all of that's going to impact the counselor's ability to experience and demonstrate empathy for the client. So empathy from the counselor to the client has been shown to be helpful, especially when the client expects judgment based on what they've experienced in the past. And then pointing out that treatment can actually help them control behavior. So there's almost an empowerment piece here of, if you want to change this behavior, you may not be able to change your attraction, but you can definitely change your behavior, your choices. That's in your power to do. Can be helpful for people who are in that earlier stage of change, that pre-contemplation, and they're believing that, yes, they'd like to not be incarcerated again, but the fact that they act out in an illegal way is out of their control. And then you can emphasize the negative consequences of refusing to change the behavior. So this is a motivational interviewing strategy, where you don't gloss over what might happen if they persist in this behavior. Instead, you invite them into conversation about really pondering, what does this look like if you go down this path of continuing this behavior? You walk it out for me. You've already been identified as someone who has done illegal sexual behaviors. So you tell me, if you were persistent in it and be caught again, what would happen next time? What would happen the following time? What would happen the following time? Where would this end up? What destination would this end you up at? CBT has been used. You can try aversion therapy, but it hasn't really been shown to be very beneficial. So, for example, you expose the person to something that would elicit that sexual desire with the paraphilic, and then you employ some sort of mild punishment like a foul odor or a mild shock. Hasn't been shown to be as effective. You can do social skills training. So remember, in the etiology, we talked about in the operant conditioning idea, their lack of social skills kept them from walking out their healthy sexual desires and attraction and urges in a way that's considered typical and that doesn't harm others. So that caused them to pivot into getting that sexual desire met in an alternative route. So you can, as the person increases in their ability to get their sexual urges met in a way that doesn't harm others and is considered more normative, then it may decrease their urgency to act out in that alternative way. There can also be sexual impulse control training. So it can work on sort of decreasing. There can be the impulse experienced, but not the follow through. Sort of like you might treat OCD, where there's an obsession, and then the impulse is to follow through with the compulsion to make the obsession subside. But you can prevent that response. They are capable of preventing the behavior, and that demonstrates that they have more control than they realized. So you can try training in empathy, and it may be productive for some. You can help them identify trigger situations and avoid the trigger situation or the trigger emotion. So if it is known that negative affect is a really highly predictive trigger for the behavior, then you can help them. So help them alleviate feelings of guilt, shame, depression, anxiety, anger, whatever it is, help them work through those emotions in healthier ways, then they don't necessarily have to follow through that trigger with the response of the behavior, because they're learning how to work through those emotions differently. And then situations as well. So, for example, if alcohol is a huge trigger for this particular individual, they may need to decide that they're not going to abuse substances anymore, because that's such a strong trigger to act out in the behavior that they may choose, okay, I'm gonna cut it off beforehand. I'm going to cut it off at the triggering level by refusing to abuse substances anymore. Now, it is known though, that none of these techniques have been shown consistently, reliably, to reduce legal recidivism. This is a really difficult, pedophilia in particular, is a really difficult illegal behavior to change. Now, I'm not saying it's impossible. Please don't hear me say that these people are doomed to a life of misery and harming others. I don't believe that, but it is worth noting that there haven't been any really strong evidence-supported treatments that can really budge the recidivism rate. So there's different castration options as well. Obviously, physical castration, where the testes are removed, is one option. It cannot be, in this country, mandated by a court. They cannot be required to do it, but it can be offered, as can chemical castration, as an alternative to a longer sentence. It's been widely used. 3% of people who have undergone physical castration where their testes are removed have reoffended. And so it's really severe, but it may be very helpful. 3%, after all, is a very low rate of reoffenders. And then with chemical castration, they're taking some type of medication or some type of slow release medication, like Depo-Provera is inserted, and then it lowers the hormonal surge and can help the person feel more in control of that sexual desire piece, which then enables them to be more capable of choosing not to engage in that sexual behavior. But there are risks of long-term use with this. Infertility, liver problems, osteoporosis, all kinds of risks and side effects. And the person who is being offered these choices has the right to informed consent, to be helped to think through all the pros and cons of this before they make a choice. And then there are some medications used, like SSRIs. I want to thank you for your attention to this presentation. I know that this subject can be very triggering for some of us, and I want to encourage you that I recognize that, and that if you need to reach out for help in processing some of the material that this has brought up, that please do so. Please reach out to your own counselor, to a pastor, to a friend that you trust to hear you well. And if I can be of help from a more academic sense, please don't hesitate to reach out to me and schedule an appointment with me, and we can talk through some of these issues. I can't be your counselor, but I am your professor who cares about your well-being and wants to ensure that you are all prepared as much as possible to help a variety of clients, in ways that don't harm you. So thank you so much.